So, good evening, everyone. This is Dr. Satya Yadav. On behalf of Society for Pediatric Cell Therapy and Transplant, I welcome you to another webinar lined up today. As promised by Dr. Satyendra Katewa, this webinar is going to be super exciting. And here we are going to discuss about cell therapy. And we all know that cell therapy has come for acute lymphatic leukemia and lymphoma, but there is a lot of progress happening beyond these two diseases as well. And I think today's webinar is focusing on that. So before the speaker comes and gives us this talk, I would introduce our chairperson for today's webinar, none other than a doyen in the field of pediatric oncology, Dr. Professor Purna Kurkure, who is currently heading the pediatric hematology, oncology, and bone marrow transplant department at Narayan Hridayalaya in Mumbai. And Madam has been a, a champion for long-term survival follow-up of patients after finishing the treatment. And she heads the UGAM group, which follows these children after finishing therapy, long-term survivors of cancer. And ma'am is emeritus professor in pediatric oncology and was previously head at Tata Hospital, Mumbai, ACTREC. So it's a pleasure to have you here, and there are so many other accolades to ma'am's name that it will take another 15-20 minutes if I go through all her achievements. But she is one of the senior most pediatric oncologists in the country. And ma'am, I would like to welcome you to today's webinar. Kindly take over and introduce the speaker. Thank you, ma'am.
Thank you, Dr. Satya, for that kind introduction. I'm sure, can you hear me well?
Yes, ma'am.
Okay. So it is really a privilege to chair this session as a person who has seen through the journey in pediatric oncology, starting from simple immunophenotyping to risk stratification to immunotherapy and cellular therapy and the development of the whole process, which I have been able to very well witness myself through the decades. And it's my privilege to introduce today's speaker, Dr. Michaela Sang, who is a senior consultant blood marrow transplant and cell therapy in the Department of Pediatric Hematology Oncology at KK Women's and Children's Hospital, which really holds very important position in the history of South Asia, where the first South Asia conference was done in 1998. And they were the leads for that conference. So I still remember the hospital and the welcome and that conference so well. Dr. Michaela Singh is a pediatric hemato-oncologist with her special interest or a clinical niche in high-risk leukemia and hematopoietic stem cell transplant. She is nationally funded PI with her research interest in translational cell therapies for devastating childhood cancers. She serves as the blood marrow transplant and cell therapy clinical faculty and director and research lead for transplant and cell therapies in the Children's Blood and Cancer Center and the research director of Seeing Health Duke NUS Transplant Center. And I'm sure as a very learned faculty, young faculty bubbling with enthusiasm, she's going to tell us a lot of, give us a lot of insight into this ever developing subject of cell therapy. Dr. Michael Sang, please take over and give your presentation.
Okay. Thank you so much, Dr. Kokore and the SPCTT CCT Society. Just very honored and happy to share a little bit about what we have done in Singapore, and also more importantly, what's going on internationally and globally for children's relapse refractory diseases. So let me just share. Can you see my screen?
Yes, we can see it now. We can move
Okay,
to the
all
next
right.
slide.
Okay. So just to start, very quickly, I think we're all familiar with the use of CD19 CAR-T therapy for relapsed refractory B lineage leukemias and lymphomas. But in pediatrics, it's more than that. And now we are coming kind of to the edge of the green grass and looking to see what the gaps are. So we need to move really beyond CD19 in pediatrics. So it's a great topic. And I think we can start first by asking what are the unmet needs. So I just briefly, there's more than just these, but I think these are the four main ones that challenge us today. One is what do you do with post-CD19 CAR-T relapse? And how do we actually prevent this? Are there better CARs than just a single targeting CAR-T that will reduce single targeting CAR-T relapse? The second is how do we tackle relapse refractory non-B lineage malignancies in blood and in solid tumors? And then the last is how can we help patients who have very poor T cell quality or fitness or very aggressive disease that doesn't allow us to perform a good apheresis? Okay, so with that, there are some proposed solutions, and I think these are kind of the major themes that we know are being worked on. So first, there's multi-targeting approaches for CARs, and we'll go into a bit deeper into this about the rationale behind this and share some data on our trial in Singapore. And for non-B cell blood cancers such as T-ALL, AML, we have novel antigens that are that can perhaps serve as the CD19 for B cells. In a similar way, CD7, CD5 have been used for T-cell ALL, CD123 and CLL1 for AML, and CD84 is expressed in both T cells and AML. For solid tumors, there are some good pan-cancer targets that are very promising and will show some landmark trials, particularly in GD2, HER2, IL-13 receptor alpha, B7-H3. And solid tumors are in itself a very different beast from blood cancers. There is the entire tumor microenvironment that has to be tackled first and foremost in order to get CAR-T to succeed. And so therefore, it can't, I strongly believe that actually CAR-T in solid tumors really need next generation platforms, either trucks or safety switches and other logic gates. If you have poor T cell quality and fitness, these are that could be potentially solved by having good allogeneic platforms like CAR-T, allogeneic CAR-T, CAR-NK, and CAR-T gamma delta. So it's not possible to cover everything. So I'll just cover kind of the main ones that are of my interest and some of the landmark articles. So we know that there are persisting challenges for relapsed refractory BLL getting single targeting CAR-T, in which 50% relapse or die, and 10 to 25% that relapse are actually due to antigen loss. And therefore, 20% still proceed to transplant consolidation. As you know, transplant consolidation, especially in our pediatric cohort, for at least for the majority of centers, is still very much TBI based. And this has significant toxicities, especially if the patients have been pre-treated heavily. And if you look at the commercial options for CD19 CAR-T, whether it's 4-1BB Zeta driven, which is Teaser, Lucel, or CD28 driven, which is the Yescarta, Zuma, the event-free survival is roughly about 12 months. And there is a plateau, at least for the persistent CARs, but no plateau for those for the CD28 co-stimulated CARs. And so this brings us to the big gap that what happens to how do you close the 50% gap? And actually, in our own in Singapore, we have our in-house CD19 CAR-T as well, and this is in-house automated, driven by the Prodigy system, compared it against the commercial Kymriah. And you can see that actually no difference. I think all CD19 CARs are roughly about the same. So we saw the same progression-free survivals of about 50%. So multi-targeting CAR Ts are really based on the fact that CARs, that antigens on even normal antigens on B cells or T cells, they have a propensity to escape or modulate. And if you have a large tumor cell burden, for example, if you see the large single cell plot on the left, you can see that actually there are a lot of small, isolated, small clones, subclones that are pre-existing that CD19 negative. So the larger the tumor burden, the higher the risk that these CD19 negative clones can be selected out under strong immune pressure. And how they're selected out is typically, at least for CD19, by epitope splicing. So the FMC63 targets a particular part of the CAR. You can see it's this number 4. And that actually gets spliced out as the antigen mutates, and therefore the antigen targeting is lost. And similarly for CD22, this happens in the same manner, and this happens in fact more rapidly in CD22. And so this brings us to the hypothesis that perhaps if you have dual targeting, you could potentially triangulate the antigens on the blasts and prevent antigen escape, because it's actually biologically more difficult to downregulate 2 antigens at the same time. So there are many ways of dual targeting, and in the interest of time, I won't go too deeply in this, but essentially there's co-infusion approaches, tandem CAR approaces, bicistronic approaches, and co-transduction approaches, and each comes with its own sets of advantages and disadvantages. So in Singapore, at least in KK Hospital, Sing Health, we embarked on this phase 1/2 tandem dual CAR T study in order to see if we could simultaneously target antigens on B cell, reduce antigen escape. And in that way, we didn't want to move empirically to consolidating our patients with transplant. And so the design of this trial was based on the fact that patients would not typically be consolidated with transplant if they went into complete MRD remission after a single infusion of tandem CAR. So our product was the investigational fresh in, fresh out GMP CD2219, manufactured over 12 days on a Prodigy platform, and patients got lymphodepleting chemotherapy followed by infusion of CAR T cells. We also simultaneously had correlative assays to look at multi-omic data that might help us to better understand what contributed to CAR T failures in our cohort, and we'll present this data at ASH this year. So the 2219 study is our first study that really leveraged on the national facilities at Actress, and we have 2 adult sites and 1 pediatric site. And we had 3 dose levels, of which one was a de-escalation level, and we had a starting dose of 1 million per kilogram with a recommended phase 2 dose of 2.5 million per kilogram. And we escalated our children and adults separately because we were not sure whether the dose-limiting toxicities would be different for each cohort. And we have found the RP2D to be 2.5 million per kilogram for the children cohort, while the adult cohort is still accruing. And we're now looking at a more enriched cohort where patients are treated with CAR T upfront when they have high-risk MRD at the end of induction and at the end of consolidation, or if they've isolated or combined extramedullary relapses. So you can see that the manufacturing is very robust and reproducible. With 12 days, we generate at least 1 fresh infusion product and at least 5 stored products for the patient's subsequent use, but high transduction efficiencies, high viabilities, and product release criteria is often just met without much issues. And this is kind of the snapshot of the early results from our trial. So at a high CR rate of 100%, 91% of these were CR MRD negative. And we have now 36-month or 3-year data, and we have not reached a median survival at 36 months, both in terms of leukemia-free survival and overall survival. So compared to what we know is available commercially, I think we've made some incremental progress there. But of course, I'll show you some of the other studies, and maybe there may be better in class dual CAR Ts out there. And I think it's worth continuing all sorts of clinical trials to investigate which are the optimized constructs. I think importantly, if you look at the swimmer's plot, the majority of these patients continue to be in MRD negative complete remission. And the important thing is this is done without transplant. The 3 transplant patients were patients that had actually relapsed with MRD positive relapse quite early on in transplant, quite early on after post-CAR T infusion. The patients were quite mixed in terms of risk. We had about 40% of the patients that were actually infused upfront, and about similar amount, 40% of patients were actually quite heavily treated post-CAR T or post-transplant relapses. 50% of patients had actually had previous blinatumomab and inotuzumab as well. So this was actually a similar construct that was investigated in Spain under Antonio Perez's group. And in their cohort, they had a very heavily treated cohort. It was a different clinical trial inclusion criteria, and 7 out of 10 patients in their cohort had failed the CD19 CAR T. And you can see that in their cohort of 10, they consolidated almost everyone with a transplant up front after CAR T infusion. And they had an event-free survival rate of 32%, so a little bit lower. But the overall survival was still very good at 70%. In China, they had a strategy of co-infusing CD19 CAR T and CD22 CAR T. And this was a study that was also co-investigated by investigators from St. Jude. And you could see that the co-infusion approach was actually quite good. In fact, they had an 84% event-free survival when they transplanted patients after having dual infusion CAR T. And this was compared to their own in-house data of event-free survival of 36% after single targeting CAR T. So it's quite a remarkable improvement. And this is actually quite a exciting study that we look forward to. This is actually at the moment in the form of an abstract presented at ASH last year, but the data is really good. So this is a bicistronic CD22-19 CAR T that is investigated by the same group actually that did a co-infusion. And the reason for this was because they saw that the event-free survival was only kind of elevated with a transplant. So they used bicistronic CD22-19 CAR T to see if they could improve this. And the results were actually remarkable with 99.1% complete remission, and almost all of them were MRD negative. 12-month event-free survival was 72.4% and 91.4%. And the 12-month event-free survival was 86%. Again, better in those that were transplanted versus 70% for those who did not. But this is still very good in a patient profile that was heavily treated. Of those that didn't undergo transplant, they did relapse, and they did relapse with different types of antigen loss. So it's still possible to lose antigen despite dual targeting. And most were treated and salvaged with a second dual CAR T approach. And it was relatively safe with CRS occurring in all patients, but lethal CRS occurring in only 2, and CAR T neurotoxicity was observed only in 16.4%. So similarly, the CD2019, I won't go too much into this because this is for relapsed to refractory diffuse large B-cell lymphoma, not really a problem in pediatrics. But the results are actually much better than what we have for pure CD19, 4-1BB zeta. This is actually a 4-1BB zeta construct. So this is about 60% plateaued progression-free survival. Okay, so I think moving quickly to T-cell ALL and other blood cancers. So you know that CAR T-cells or TLL are more difficult. I think there are less trials out there and probably less mature trials. But the common targets are CD7, 5, and 38. I just want to point out the main challenges for CAR T-cells for T-cell ALL. First is fratricide that can occur during manufacturing. And this can be overcome by using potentially other immune effectors like NK and T gamma delta. Protein expression blockade of CD7 was a trial that was conducted in Singapore as well as in Italy. And the results I'll share in a while. And of course, base editing approaches to basically knock out CD7 expression on the T cells that are transduced with the CD7 CAR. Another challenge is that there is almost indefinite T lymphopenia that may need transplant unless you are lucky and you have a CD7 negative or dim T cell recovery of which happens, but not always. The other thing is that CD7, CD5 we know downregulate quite fast as well, and there is definitely antigen escape that occurs in T cell ALL after CAR T. The other problem with CAR T cells for TLL is that you can get transduction blasts, and so we're looking at allogeneic options as well as using other types of effectors like NK and T gamma delta. So on the right, really just kind of a snapshot summarized by Bernice, one of our colleagues, on the various different trials investigating the different antigens for T cell ALL. So just a word or slide on protein expression blocker. So essentially, this is what we call a cassette that we put adjacent to the CAR, and it's expressed together with the CAR. But what happens is that this antibody is engineered, and it is anchored to a retention segment. So it looks like this, a pebble. And what this pebble does is that the antibody fragment binds to CD7, which is normally otherwise expressed, and the ER expresses it onto the surface. So what happens is that the antibody from the pebble binds the CD7, and the anchor then anchors it in the endoplasmic reticulum, and so it stays within the ER and it doesn't get expressed onto the surface of the T cell. So in that way, you get a T cell that doesn't have the CD7, and so it's no longer a target of its own CAR, and this avoids the problem of fratricide. So when they did a trial of, I believe it's 30 of 17 patients, I apologize, 17 patients, the results are remarkable because for patients that were highly refractory, you could see that after a single infusion, the majority were MRD negative, except for one with progressive disease. And you could see that there's actually one long-term survival without transplant. This boy, I think it's a famous British boy, and I think he recovered with a CD7 negative T cell recovery, endogenous recovery. Most of the other patients that were survivors had transplant consolidation, and there were of course relapses, and the relapses died either from infection or relapse. But I think it represents progress for relapsed refractory T cell ALL, and overall survival is around 50-something%. And as you can see, the median survival is also not reached. So just a word or a few kind of touch points on other platforms that CARs could be transduced. So we have T gamma delta cells that are being explored. So one of our colleagues is looking at cord blood derived gamma delta T cells engineered with CD5 and I believe B7H3. Of course, we're doing the same with CAR NK, and this is just a snapshot to show that CAR NK is up and coming, but at the moment it's the majority are still being used for CD19 as a target. You can see the two big dots here, and these are used in BAL and autoimmune disease. And the other big group that is using CAR NK is the multiple myeloma. And if you can see, autoimmune disease are really up and coming, and I think CAR NK might work best in an autoimmune setting because of its persistence and the fact that autoimmune disease may not really require the long-term persistence for CAR T. One thing good about the NK cell is that there are many sources of NK cells. You could get it from cord blood, iPSC, NK92, peripheral blood, and of course in many of the trials they don't disclose where it comes from. And most of the trials actually using CAR NK as an allogeneic vehicle instead of autologous. So one of the nice things about NK is that there are also non-CAR directed killing mechanisms. So you both have CAR directed and non-CAR directed. So there's a different mechanism of killing that could potentially overcome antigen escape. It's allogeneic, it's low toxicity compared to a T cell, and you can get it from multiple sources as mentioned. And the challenges include transduction, difficulties and manufacturing can be quite complex, needing feeder cells or non-feeder systems. Persistence is an issue in vivo, and it can be inhibited in the tumor microenvironment, so not so good at the moment for solid tumors. Of course, to modify this and to make this better, there are lots of cell engineering work that can be done, as we have done for T cells. But I think the beast and the real challenge is cell therapy in solid tumors. And as you know, in pediatric, actually when you look at leukemias, there are maybe about 50% of all our pediatric childhood cancers, but the other 50%, put them all together, are actually solid and brain tumors. And these, when they relapse or refractory, actually have very, very little options compared to leukemias, right? So what are the challenges in solid tumors? I think you can triangulate them again. And I think these are the three main roadblocks that I think remain true to today. First is antigen. Finding the right tumor antigen in solid tumors is quite different from the lineage-defining antigens in blood cancers, because solid tumors derive from endoderm, mesoderm, epiderm. So all these actually are shared with our normal tissues. So to find a very specific tumor-associated antigen is more difficult. And in our, as you know, solid tumors are very heterogeneous. Lots of fibroblasts, lots of tumor microenvironment, and so the targets are really quite heterogeneous compared to a clonal blood cell that's gone become a leukemia. The second problem is homing. So as you know, homing is into the tumor microenvironment, and through the very thick capsule that often encapsulates solid tumors is a problem. And the tumor microenvironment in the solid tumor is particularly suppressive and unfavorable for immune cells to penetrate. And that's particularly true, especially in the pediatric oncology tumors, compared to some of the hotter tumors in the adult setting. So this was done, I did a slide in 2021, so it's about 4 years ago, maybe a bit outdated, but I think in general, this remains true. Some of the main CAR-T trials and the most promising targets are here. So CNS tumors are very, these are really unmet needs. So EGFR, HER2, GD2, B7H3, these are targets. I think you add to this list IL-13 receptor alpha as well. Sarcomas are also very difficult to treat once they relapse, and HER2 and GD2 appear to be promising in this area. Neuroblastomas, as you know, have the highest treatment morbidity, both financially and in terms of treatment toxicities. And at least in countries where anti-GD2 is given upfront as part of frontline protocols, and once they get refractory, there's really very little that can be done to salvage. And so there is CAR-T GD2 that have been developed as a potential bypass, and we're seeing some early phase results come out. So this is one of the very nice, I would believe it's landmark, in my opinion, for solid tumor CAR-T in pediatric oncology. So this is a GD2 targeting CAR-T in high-risk neuroblastoma conducted by the group in Bambino Gesù. So this is a phase 1/2 trial, and there are 35 patients that comprise of both clinical trial and hospital examined patients. And they treated the patients on a dose escalation of 3, 6, and 10 million per kilogram of CAR-T cells, and they had a dose expansion on 10 million. So it's actually quite a high dose that they gave. And the 5-year overall survival is actually impressive for a relapsed refractory group of 67.6%. Can't really see a plateau, but I think this is actually quite a late endpoint for a solid tumor that's a relapse through multiple modes of treatment. And the event-free survival is 52% at 5 years, and this seems to have plateaued. So that's quite promising. And you see that the response rates are best in the bone marrow. So if you have residual bone marrow disease, potentially that's very treatable by CAR. Less so in the bone and solid masses, but surprisingly, lymph nodes are actually quite refractory once they are a site of relapse. The CARs are generally safe, with mainly cytopenias and CRS being the major toxicities. So just, CAR T-cell and DIPG, this is essentially incurable cancer, fatal, with a median overall survival of 11 months, and the 5-year overall survival is dismal. Most of the children are palliative care patients as well, and cytotoxic chemo has not improved outcomes, and immuno-oncology and target agents remain very, very investigational. And unlike GBM, in pediatrics, our DIPGs, or we call them diffuse high-grade gliomas now, these are actually very actually what we call immune exclusive. So they actually lack a lot of the CD3 cells, unlike GBM. Actually no TILs that can be found in DIPGs. And in the last 1 year, there were 2 landmark CAR T trials for DIPG, GD2 and B7H3. I'm not sure whether in India you see the same thing, but this actually generated a lot of excitement in the parent support group for our DIPG patients. So almost everyone is kind of looking for options for CAR Ts for their child with DIPG. And I think the results are actually, they give a positive signal, but they are really far from being fully a good cure. But what we can see, at least in the anti-GD2 trial, is that at a low dose of 1 million per kilogram, they saw a high rate of CRS and tumor-associated inflammatory neuropathy, which is a specific CRS associated with CAR Ts being infused directly into a tumor site in the brain. And in this small cohort, the first 3 patients progressed within the first 3 months, but they realized that these patients actually responded to intracranial or intraventricular administration. So they amended protocol and they started to infuse it intracranially. So I think the route of infusion is actually quite important for solid tumor CAR Ts. And from patient 4 onwards, there seemed to be improved prolonged survival in these patients, and they gave multiple doses, up to 16 doses for some of these patients. So you can see here, unfortunately, most of the patients succumb to disease with varying progression-free survival time points, but as long as up to 30 months, compared to, as I mentioned earlier, about a median survival of 11 months. So we can see that at least for some of these patients, they could prolong the duration of survival by at least twofold. And there's 1 patient with a long-term response. So I think this itself generates hope. Skip this. So similarly for B7H3 CAR, the protocol is a little bit more complex. They had multiple dose escalation cohorts. And I think, the main thing to highlight is that there are actually 3 patients alive and more than 40 months. And these are patients with DIPG. So, this is promising, but I think there is also a group that they found that's clearly futile. And these are patients that have progressed before the CAR T. So I think that maybe the key messages here are that perhaps CAR T in this particular group of patients need to be given very early at diagnosis, and potentially the route of administration makes a difference. Just to highlight, TIAN is a new toxicity associated with DIPG CARs. This is actually one of our patients that we sent to China for CAR T. You can see that her DIPG was progressing after ONC201, which is a small molecule. And this was her DIPG pre-infusion, which was considered stable and small. So we sent her over, and she had this triple CAR T with GD2, HER2, B7H3. They gave her 2 infusions, 3 weeks apart. And you can see that 1 month post-treatment, there's an enlargement of a tumor with extension of the peritumoral, edema, and the tumor bulk actually looked bigger. So I think at this time, there was a lot of debate whether this is tumor progression due to CAR T failure or tumor-associated inflammation. And I think it was very difficult actually to really decipher, but eventually it turned out to be actually more a neurotoxicity. The patient came home but passed away from cerebral edema. So I think, this is a summary of points and future directions that for solid tumors and especially for brain tumor CARs still remains a proof of concept. A lot of safety studies are needed. We should be biomarker driven because solid tumors are heterogeneous, and we need to find a way to overcome inhibitory tumor microenvironments. There's dual targeting. I think all solid tumors should be dual targeting to begin with. We should look at ways to make the CAR-Ts more persistent. And I think local regional delivery would, at least in the short term, overcome homing problems. So I think with that, hopefully that gives a snapshot of, what is there to do, that we still have a long way to go to find cures beyond CD19 CAR-T. Thank you. So I guess we'll be happy to take questions.
Thank you very much, Dr. Michaela. Poona ma'am, are you there?
So I don't see anything in the chat. I was just looking at the chat box, and if there are any questions, but if there are none, then perhaps.
Ma'am, may I ask a question, ma'am? A couple of
Yes,
questions
please.
from our
Yes,
side.
yes.
So first of all, thank you very much, Michaela, for that very extensive cover of a very difficult topic. So I think we deliberately made it beyond CD19 because I think we've been hearing CD19 for a long time now. It's been thrashed to death. So we wanted to just know from you where the field is heading and what are the challenges that I think you beautifully covered it. I had a question on allogenic CAR, So we understand the problems of allogenic CAR and addressing the GVHD and other things and strategies being done to circumvent those. But NKs do not have that concern, So what do you think that the field will take allogenic towards? Will it be more towards allogenic CARs or more towards allogenic NKs? And if NKs, I don't see a lot of kind of studies being coming up or data being coming up through in allogenic NK. So what are your thoughts on that?
I
Thank
think
you.
thanks, Sunil. So I think NKs are being investigated. I think mainly I would say the challenge for NKs are two. One is the manufacturing. So I think NKs are particularly hard to transduce, but of course there are now different pseudotype vectors for manufacturing NKs. And the second is the persistence of NKs. So the persistence of NKs is notoriously short-lived compared to T cells. And I think for diseases like leukemia, at least leukemia, the persistence is actually very important for cure. So I think in that way, NK is as allogenic for B cell leukemia is probably not going to replace CAR-T, but I think NK may have a role for other diseases like I think T cell ALL. So we are actually doing an NK for T cell ALL as well, because I think we do want T cell ALL, you do have to transplant anyway, most of them, and we want something short term so that you don't have prolonged T lymphopenia. So I think CAR NKs may be useful in that regard. Also, T cell ALLs are harder to do autologous because often at relapse, you can't really differentiate between transducing a blast and a T cell. So NKs do avoid that problem. So I think CAR NKs as allo vehicle will find its role in our field. Yeah, but personally, I don't think it will replace CAR-T as allo for at least for BLL. That'd be my take.
One more thing before Dr. Satyendra comes in is, on the T cell ALL, I think you showed us some data as well. I still wonder, why would we wait for a spontaneous partial T cell recovery? So, I still think that, as soon as they're in remission and quickly, get them to transplant rather than have the lymphopenia quite prolonged and then have problems of that as well, and have this unexpected recovery in some, and some don't recover. So again, your thoughts on that? I'm just trying to, I'm intrigued with this idea of not having transplant inbuilt in a T cell CAR T trial. Thank you.
So we share the same thoughts actually. I think we actually had this exact same discussion earlier this afternoon, and I think we also agree that actually for T cell AL, it'd be safer approach to actually transplant them once they're in remission, if they were eligible and suitable for transplant. I think maybe for some patients, they may have had too much toxicities, or they may not be willing to transplant, maybe patient's choice, and they just observe. And I think fortuitously, because of a few patients, we realized that T cells can recover with CD7 DIM. But one of the things I learned this afternoon as well, I'll share it, is that CD7 DIM or CD7 negative T cells are actually more exhausted and less activated type T cells. So they are not going to be your normal T cells. And so infection risk can still occur. Yeah, so I agree. I think essentially it should be offered as a package. Once you have a T cell cell therapy approach, we should follow up with a transplant.
Thank you very much, Satyendra.
Yeah.
Dr. Satyendra.
Hi, Michaela, thanks for that lucid talk. Now, my question is about the DIPG cards. So, has anyone, I know once we have given the radiation and the patient is good for good 8 months, 6 months, and then we have used, has anyone done it right after the primary radiation treatment where the disease is almost in remission and the tumor microenvironment is at its weakest point, and where I think the homing and the tumor microenvironment are not that big a challenge? So because DIPG is that big a thing, has anyone done right after this the radiation and then the CART, and maybe the result might have been
I think those two trials that I showed earlier, their design is to do it very upfront. So I think the minute they're diagnosed or they are just post radiation, just completed radiation, that's when they give the CARs. So actually for a patient, and I guess like it's not even my field. I'm not even a neuro-oncologist, but this patient of ours went around looking for CAR T trials, and essentially was excluded from almost all the major ones because they were actually infusing the CAR Ts very much earlier than this patient was in the stage of a disease. So I actually think most people are thinking the same. Infuse early after radiation. The earlier the better. Don't wait for progression. A lot of the trials as well, they have eligibility criteria of Lansky score more than 60, which is almost impossible for a patient with DIPG that has relapsed or is progressing. So yeah, so I think they are being selective as well, at least for their phase 1, phase 2.
And can I just one supplementary question? So the patients who have done okay, because there are few patients of DIPG who have stayed free into the remission, have we found something into those patients where they relapsed? This just the question. So if your patient beyond the DIPG is this much into the tumor load versus the expression of the antigen beyond this point, they did well, or this is we haven't looked at, or you guys nobody has published it as yet?
I don't recall coming across that in the paper, but I think the paper, what they highlighted was the timing of the CAR T, being earlier, more upfront. No, they didn't highlight that. I think the GD2, but this is in neuroblastoma. They found that the patients that relapsed actually had higher circulating MDSCs, so the myeloid suppressive cells. But I don't recall something so correlative in the DIPG class.
So the last question. So the patients where they had in the anti-GD2 cards, where they were circulating cells which were suppressive of the cards, has anyone doing further on to them, like antibodies to suppress them, or it is just
it's the work in progress. Nobody has done anything to them. So means once you have done the CART and you see those MTSCs, and then are we doing something to suppress them in terms of by antibody and the apoptosis, or has anybody done that thing, or it is no, nobody has. I'm just asking question.
I am not aware of anyone targeting the MDSCs that are circulating, but I think there are people exploring tumor macrophages that potentially target the inhibitory microenvironment better. But yeah, I'm not to my awareness. That'd be great if there was something. Yeah.
Okay, thank you.
Dr. Chetan, you have raised a hand, please. Go ahead.
Yeah, so Makela, once again, a very nice lucid talk covering everything that can occur after CD19. So I just wanted to see, with Wing being there and Dario being there, what is your experience or take or the discussion on NK cells in the solid tumors as well as leukemias?
NK in solid tumors
And leukemias also.
and leukemias. I would say that currently, at least in Singapore, the NK cells are being used more for blood cancers. So like Dario, okay, I don't know whether I should speak about his projects, but as you know, they have an adapter CAR, right? So they have a CD16 CAR that basically mimics the CD16 of the NK and basically binds to small molecules that can engage both CD16 as well as the tumor antigen. So that's one, but I haven't heard yet that they are doing an NK. At our end, everything is still very experimental at the preclinical stage, but we are working on NK, on a CAR NK, yeah, potentially just CD19 first, just to get the manufacturing optimized on a target that we're familiar with. But also I think the foreseeable utility is that the NK will be an allogenic type of cell that we can use for things like for T-cell ALL, AML, yeah.
Great.
I think it's a time to close this session and move on to panel discussion where we can further answer our queries and get some more information. So let us go on to the next phase, that is panel discussion, and I invite Dr. Rajat Bhattacharya for conducting the session.